My name is Sarah Slater and I'm an oncologist in GI cancer. So I look after a mixture of patients, mainly those receiving chemotherapy, but of all cancers of the gut, so stomach, esophagus, bowel, pancreas, liver. So we have generally an older population of patients and we look after them over the whole of Barts Health, but quite a lot of our patients come from Whipps Cross, so Chingford, outer edges of London going into Essex. And we found we were getting poor patient-reported outcomes. We were doing very badly in the patient survey. We decided to look at all the aspects of how we deliver care, and the primary one is we deliver very much an outpatient service. Is if we can't get the outpatient clinic appointment right, then we're running into big problems. We were bringing patients to us. I just come to work, everybody comes to me, whereas actually if what we're trying to do is improve patient care, we should be a bit more diverse, we should be a bit more dynamic and proactive. What is it patients want from the service? What do they want to have the appointment? So we did our own in-house survey about what upsets patients or what they want from us, and the outcome of that was they really hated the long delays and felt slightly frustrated that a lot of the questions they were asking was something that would have taken 5 or 10 minutes on the phone, and that is, that's exactly right, that's exactly what we should be doing. We set up a pilot of me doing a few cases per week, mainly actually to educate me on how to use the system. I am absolutely technophobic. If patients of 75 and 85 can do it, and they are very, very happy and very keen to do it without exception, then I really think I can do it. And we did a pilot and it went down incredibly well. Patients liked it. So the questionnaire was, again, is there something we could do before we dial into a patient that would optimize that consultation? So we looked at what questions do we routinely ask patients on chemotherapy or off, and that once we devised that, we could send it to a patient, they could look at it, answer, and we could see the results before we phoned in. Now that's made an enormous difference. You don't waste time going through a checklist, but secondly, it means you can focus on the things that are important to the patient, not on what you think is important. And there is a free text area where they can tell you other things that are of interest. And again, talk to colleagues. If what we're supposed to be doing is patient outcome measures, then we need to know what patients think, not what you think. Telephone are very easy because you do tend to kind of go through a checklist of questions, and you don't realise until you've done a virtual what you're missing, and what you are missing are the really obvious things, which are the visual clues. So when you have somebody and you say, if you had any problems with the chemo, no vomiting, no sore mouth, everything okay? And they go, yes. That's the end of your telephone consultation. If you do it in a virtual, you can see the hesitancy or yeah, that was fine. And those are incredibly important for what we're trying to do, which is make sure we're giving patients the best care. There's nothing like someone saying, my fingers are really sore, and you say, show me, and you're going to go, and you think, that's all right, or gosh, that looks awful, you really should be coming up to see us. So I think there's no replacement for virtual. Often it is just looking at someone's thinking, you haven't shaved today. You're somebody who normally has great pride in your appearance, and you come, fully dressed up. So there is a problem, but you're just going to do it, you're telling me everything's okay, I can see it's not. And that's what you would miss if you didn't see them on a virtual. We were already set up to a large extent within the Ortus system. So what we did straight away was we're going to convert all our appointments onto the Ortus platform, including the new consultations. So for us, it was a fast tracking of something we already had in our minds to do, and it was a great opportunity to say, listen, this is the time to do it, because patients now can't come up, we're all ready for it, we know how to use the system, let's just go for it. And certainly doing that, converting into you would never go back.
COVID-19 presented a really interesting challenge for wards with vulnerable populations, like patients with gastrointestinal cancer. These patients require ongoing follow-up with their clinicians, medication titrations, and really consistent biometric monitoring. But all face-to-face appointments had to be suspended to protect patient safety. This meant that all patients that were booked for appointments for the months May to June had to be moved to a virtual platform really quickly. To rapidly integrate these patients to the platform, we created a utility to batch upload multiple patients and rebook their existing appointments in the virtual environment. Using this method, we were able to upload 200 patients in just an afternoon. Patients were then notified of their appointments by SMS and provided ongoing technical support around accessing the service or attending a patient appointment. The Ortus-iHealth platform was then used as a patient portal that allowed for safe patient follow-up, virtual consultations, and the capture of subjective PROMS data and objective biometric data, like heart rate and blood pressure, continuing to provide personalized care in a time of crisis.
We have an opportunity again for patients who often have relatives, family, friends who need to be present, who obviously were taking days off to come and see us. Now, we can be doing it on a joint split screen. I mean, from my point of view, that's ideal. You're able to assess someone's fitness, you're able to talk them through about their cancer diagnosis, you're able to make decisions about treatment, and you have met them and they've seen what you look like.